A meningioma is a tumor that arises from the covering of the brain. 80 to 85% of meningiomas are benign. Approximately 10% of them are what we call atypical. What this means is that they have a higher chance of recurring despite complete surgical resection. The remaining 5% of meningiomas are called malignant meningiomas and can be quite aggressive. Treatments for meningiomas vary. If it is small, we frequently don't do anything other than follow-up imaging. Surgery or radiation is reasonable when a meningioma is greater than approximately 2 centimeters, if it has shown signs of growth on follow-up imaging, is causing symptoms such as seizures, weakness, or vision difficulties, or if it is causing an inflammatory reaction in the adjacent brain tissue. Meningiomas can occur anywhere along the covering of the brain. The risk a meningioma places a patient at is highly dependent on where it is located. I will show a series of meningiomas both before and after surgery. All of these meningiomas were benign grade 1 tumors. This is an MRI of a patient with a frontal meningioma. She has a history of breast cancer, and the concern was whether this tumor was in fact a return of her breast cancer. We see it is located in the right frontal lobe. It is immediately underneath the skull. This was a relatively straightforward tumor to remove. I made a bone cut through the frontal sinus, which gave me direct access to the tumor. In this case, I did not see the brain until the majority of the tumor had already been removed. By doing the surgery through this approach, I am able to avoid manipulating the brain tissue, thus decreasing the risk of surgical injury. Here are her films after surgery. We can see there is no residual tumor visible. The patient did quite well and has returned to a normal life. Here is an MRI with a slightly more complex meningioma. This is called a clinoidal meningioma and requires a particular approach called an orbitozygomatic craniotomy. While this is a benign tumor, critical structures are at risk. The optic nerve and carotid artery are sitting immediately below the tumor. Preoperatively, the patient was advised the biggest risk involved her sight in the right eye. Stroke was also a risk. However, following the same rules as above, avoiding unnecessary manipulation of brain tissue, complete resection was achieved. Postoperative imaging shows no evidence of tumor recurrence. The only complication she has is headaches in the right temple. The final meningioma is much more complex. It sits between the occipital lobes and above the cerebellum. While the tumor's anatomy is complex, the anatomy of the surrounding brain is simpler than the previous case. The occipital lobes affect vision, and the cerebellum controls coordination. The patient was advised of these risks. After about 10 hours of surgery, the tumor was completely removed. Postoperative imaging shows no evidence of tumor recurrence. Postoperatively, she experienced flashing lights in her vision, which lasted 3 to 6 weeks, and then completely went away. So as you can see, the question that is more important than what is a meningioma is where is the meningioma? The location of the tumor, in my view, is the initial factor involved in determining whether observation, stereotactic radiosurgery, or conventional open surgery is the appropriate treatment.